Neilan. So yeah, get started.
So thank you everyone for joining us today for UCLA Cardiology Grand Rounds. It's my pleasure to introduce our speaker for today, Dr. Tomas Neilan from Massachusetts General Hospital. He's an associate professor of medicine at Harvard Medical School and director of the Cardio-Oncology and co-director of the cardiac MR-PET CT program at MGH. He completed his MD, University College Dublin, and clinical training in Dublin and MGH, and he has a clinical research interest in treatment of cardiotoxicity after chemotherapy, radiation, and particularly immunotherapy, including immune checkpoint inhibitors. So it's our honor to welcome him to give a Grand Rounds talk today entitled Cardiac Toxicities Among Patients Treated with Immune Checkpoint Inhibitors.
All right, everyone. Well, thanks very much for the very kind invitation. I know a lot of people on this call, so it's a real pleasure to give it to speak again. I'm going to just take a little bit of a step back for those people who don't live as much in the immune therapy world as Dr. Yang and some more of us, and just talk a little bit about multiple different approaches to leveraging the immune system. And if you take a broad look, as shown here on the left-hand side, you can leverage the immune system using cell-based therapies, which is CAR-T, and CAR-T and cardiovascular toxicity is an entire presentation on itself. You can have a conversation and focus on cytokines, on vaccines, oncolytic viruses, on BiTEs. The BiTE conversation is very interesting, especially when it comes to some of the other malignancies, but I'm going to focus on some of the solid malignancies and treatment with immune checkpoint inhibitors. And this is a very short primer on immune checkpoint inhibitor therapy, where T cells will attack cancer cells if they recognize them. Sometimes the T cells will not recognize cancer cells as bad, as these cancer cells carry protein that act like masks. One of these masks is PD-1. There's multiple masks. Or PD-L1. PD-1 on T cells binds to PD-L1 and says, oh, these are healthy cells. And immune checkpoint inhibitors are drugs, often monoclonal antibodies, that block PD-1 and PD-L1 and remove the blinders that prevent T cells from recognizing these cells as cancerous. When the FDA approved these immune therapies, they approved them on the absolute understanding that you can't, in a non-specific way, leverage the power of the immune system without anticipating immune-related adverse events. These immune-related adverse events are extremely common. 70% of patients who get an immunotherapy will get an immune-related adverse events, but that doesn't mean these are serious. The majority are extremely mild, benign, and easily managed. Majority do not need to hold immunotherapy. Majority are like localized skin issues or mild colitis and can be easily managed. Small percentage are serious and require the cessation of immune therapy and the starting of immunosuppressive agents. We're cardiologists, and so I'm going to focus on cardiovascular disease related to immune therapies. So this is a consult, and this is a patient who I still see. He's a 49-year-old male with renal cell, past history of hypertension, diagnosed in 2015 with renal cell, started nivolumab, one of these checkpoints. Shortly afterwards, was at lunch and was a bit sweaty, nausea and fatigue. And he presented to the emergency room and had an EKG, which is shown here on the screen. And you can see there's non-specific STT wave stuff on the EKG. Had troponin, this is high sensitivity troponins, which is the bane of our lives. And they're elevated, detectable, but they're barely detectable and flat. NT-proBNP was normal. It was an emergency room, it was a weekend, and so the patient had a stress test, and the stress test, good exercise capacity, 10 mets. Imaging shown on the right, no ischemia, no infarction, normal left ventricular systolic function. Patient was discharged. Presented to his oncologist 2 days later, and the oncologist repeated the EKG. The EKG was similar. Oncologist said, Tom, what do we do? And so I suggested an echo, even though on the nuclear, his ejection fraction was normal. Had an echo, no pericardial effusion, no wall motion abnormalities, no myocardial thickening, etc. And left ventricular ejection fraction was 58%. And I'd been a little bitten by care of a patient a couple of weeks prior who had a very benign presentation and turned out to have immune checkpoint inhibitor myocarditis, and unfortunately had a really bad outcome. And so I was very conservative when I approached this individual patient. And so I said, I'm still not sure that EKG is abnormal. could we do a cardiac MRI? And by luck, there was a cardiac MRI slot that wasn't too far away. And so we weren't going to interrupt their immunotherapy cycles because they're typically given every couple of weeks. And so this patient had a cardiac MRI and, we do tissue characterization, no edema on T2 imaging, no late gadolinium enhancement. Resting systolic LV function was borderline of 55%. Mild diffuse hypokinesis, no evidence of myocarditis. And something struck my eye is this is an MRI, and typically the ejection fraction on the MRI, I know this is not apples to apples, but typically the ejection fraction on MRI is higher than the ejection fraction on an echocardiogram. And here now we were seeing an ejection fraction which was measured on nuclear at about 70% and on echo 58% and now on MRI at 55%. And that kind of bothered me. And so I said, I can't be sure. Then best test we have available is a native heart biopsy, which is a big undertaking. But the patient underwent a native heart biopsy, which showed a lymphocytic myocarditis. So the patient was diagnosed with myocarditis and then started immunosuppressive therapy and had the EKG, the offending EKG repeated, which is shown here. And the offending EKG had normalized. And typically what we do is we do a gram of methylprednisone per day. And after 3 days, we transition to oral prednisone with an outpatient taper. And a couple of slides later, I'm going to talk about the different ways of approaching immune checkpoint inhibitor myocarditis. So what's the incidence of immune checkpoint inhibitor myocarditis? It is widely variable. And so there are lots of data out there reporting the incidence. I think the best data we have actually are from a very recent New England Journal paper where they looked serially at troponins and EKG. It was single agent nivolumab versus combination therapy with relatinib. And relatinib is one of these LAG-3 inhibitors that's now FDA approved. And in that, in patients with a single agent immune checkpoint inhibitor, incident rate of myocarditis of at least 0.6%. And that was probably an underestimate because they actually only tracked these patients for the first 2.5 months or so. Then there's like 25 to 30% of patients who present after that period. So at a minimum 0.6% for single agent therapy, and with the combination with relatinib, it was 1.7%. So I think the ballpark figures I tell people are single agent therapy about 0.75%, combination therapy, if it's with relatinib, it's at least 1.6 to 1.7%. If it's with CTLA-4, it's probably about 1.3 to 1.5%. And so that those incidence figures seem relatively low, so it seems so why are we having this conversation? And if I show a picture of somebody at the top left or top right of the screen, it's because that's the individual who drove this study. And this is Dr. Saad Mahmood, who's now at Cornell, directs their cardio-oncology program in New York. And what Saad showed was that the case fatality rate was at least 20 to 30% versus general myocarditis is far lower. And there's significant morbidity and mortality beyond that, which include cardiogenic shock, cardiac arrest, VT, and complete heart block. And what Saad also showed was that 38% or almost 40% of events occurred in patients with a normal ejection fraction. And so we recognize that the incident rates with immune checkpoint inhibitor myocarditis are far lower than incident rates of other things like colitis, pneumonitis, hepatitis shown here on the right-hand side. So they have much higher rates of IRE, immune-related adverse events, or IREs reported. But in this study, the case fatality rate with myocarditis, you can see, is relatively far higher than these other entities. So that's why people get bothered by immune checkpoint inhibitor myocarditis. And the data behind the role of PD-1 and PD-L1 and CTLA-4 in cardiovascular biology are relatively well established. And this is a paper which is not a new paper, published well over a decade ago, and actually over 2 decades ago, where they show that there's an upregulation of PD-L1 in animal models of myocarditis. So you induce myocarditis in a murine in mouse model, and you get upregulation of PD-L1. If you knock out PD-L1, or if you introduce a PD-L1 blocker, those animals do worse. They have more histological injury, they die easier. And here in the study, they knocked it out using a monoclonal antibody, and the animals had higher troponin and histologically did worse histological injury. There are also more recent data, 2018 New England Journal article about shared antigens between the tumor, cardiomyocytes, and skeletal muscles. This is an interesting idea because 20% of patients will get overlap with myositis, and those patients who get myocarditis and myositis generally tend to do worse. Up to relatively recently, our insight into cardiovascular, into myocarditis was relatively hampered because we didn't have great mouse models. This is a publication in 2020, and as everyone in this this talk will know, Dr. Jim Allison received the Nobel Prize for CTLA4 and discovery of CTLA4 and its critical role. And Dr. Allison and his team, recognizing that immune checkpoint inhibitor myocarditis was one of those feared complications, created this elegant mouse model where they successfully recapitulated the physiology. So this will obviously offer remarkable insights into the physiology and start to give us a move towards better understanding. So when you get the call, when you're the resident or fellow, and you get the call saying, we have a patient who has this suspicion of immune checkpoint inhibitor myocarditis, you got to think about what do you do? And this is what you do. You do a history, you do a physical exam, you do biomarkers, echocardiography, cardiac MRI, and the myocardial biopsy. Nearly all patients will have an elevated troponin, well over 90%. And the individuals who don't have an elevated troponin are typically folks who present much later. We're starting to recognize that there's this non-inflammatory myocardial dysfunction that occurs with immune checkpoint inhibitors, and what non-myocarditis cardiomyopathy that occurs with immune checkpoint inhibitors, which can present quite late, usually after 6 months or so. The vast majority of the acute myocarditis that you worry about presents early with an elevated troponin, EKG abnormalities, elevated NT-proBNP. But there's a tail as well of individuals who present late, and you do a biopsy and they have no myocarditis, but they still have a cardiomyopathy that you can't explain. The former are a little more easy to understand because they have active inflammation, so they need something to suppress their active inflammation. The latter, we have no idea what to do with except beyond GDMT. We also perform an EKG, and Dr. Dan Zlatov led the study showing that there's an increased QRS width among patients who develop myocarditis. He also showed that the increasing QRS width was prognostic. The left ventricular ejection fraction is measured as standard among patients when the concern is immune checkpoint inhibitor myocarditis, and it's normal in about 55 to 60% of cases. So you can't use a normal ejection fraction to exclude the diagnosis, as everyone knows, but you also can't use a normal ejection fraction to say to the patient, no, you're fine. This is very different to myocarditis related to other entities where, in myocarditis related to other entities, the ejection fraction is preserved. You usually tell the patient to rest, come back and see their care team in a couple of months, and if they typically get the all clear to resume normal activities. Here, the paradigm is very different in that even with normal EF, this can be a malignant phenotype. In the cardio-oncology world, we've known for years about the limitations of ejection fraction when the patient's at risk of traditional cytotoxic chemotherapy-related injury, and so we measure global longitudinal strain. And here, with immune checkpoint inhibitor myocarditis, there is a reduction in global longitudinal strain. That reduction in global longitudinal strain is not so relevant for patients with a reduced ejection fraction, but it's very relevant for patients with a preserved ejection fraction because it gives us another tool in our echo tool bag to determine whether this patient, how high our suspicion is for ICI myocarditis. The global longitudinal strain story got a little confusing though recently with this this elegant publication in European Heart Journal, where they said, okay, we're going to do two things. We're going to have a mouse model where we give immune checkpoint inhibitors, and we're also going to do a cohort study whereby we follow patients with melanoma who get immune checkpoint inhibitors. And we're going to serially measure global longitudinal strain. And what they showed in the patient cohort and in the mouse cohort is that there's a reduction in cardiac function as measured by global longitudinal strain without myocarditis being present. So it made the whole area a little bit more confusing in that you can get systolic dysfunction in the presence of after administration of PD-1 and PD-L1 and it not be related to myocarditis. And I think maybe that systolic dysfunction you get might, in the absence of myocarditis, may explain in part the tail we mentioned later of some patients who present with a non-inflammatory cardiomyopathy late after immune checkpoints. And what they showed was the rationale in the mouse model anyway was that the reduction in systolic function was due to a T cell infiltration into the myocardium that didn't cause breakdown of the cardiomyocytes. and breakdown of cardiomyocytes is required for the diagnosis of myocarditis. And so, and this would be a normal response, right? You give immune checkpoints, you got to get a T-cell infiltration because that's how they kill the tumor. Dr. Lily Zhang out of Montefiore then asked a question about cardiac MRI, gold standard test in the assessment of myocarditis. And she showed all these pretty pictures on the left, which can represent different kinds of myocarditis. And these different kinds, and so you can see no late gadolinium enhancement. You can see patients who have transmural late gadolinium enhancement, and we've biopsied the transmural cases, and despite it looking like an infarct pattern, it's always myocarditis. You can see mid-myocardial, subepicardial, this diffuse pattern, multiple different patterns are shown here on the bottom right. When you aggregate the data though, what do you generally see? And you generally see that in about 50% of patients who present with a normal ejection fraction, they can have biopsy-proven myocarditis without late gadolinium enhancement. In about 30% of patients presenting with a reduced ejection fraction, they can have biopsy-proven myocarditis in the absence of late gadolinium enhancement. That means one of the classical approaches to diagnosing myocarditis in these patients, i.e. looking for late gadolinium enhancement or looking for edema and black blood imaging, might be absent in these patients, yet they still have myocarditis using the gold standard technique. And so that's a little bit challenging, right? Because you've done your echocardiogram, you've done your cardiac MRI, and you still really don't know. If it's positive, great. If it's negative, though, you're still left with some diagnostic uncertainty. And the reason for the negative late gadolinium enhancement is time, right? Because a lot of these patients present early and they don't have time to develop late gadolinium enhancement. And so it looks like that if you delay the performance of the cardiac MRI, which you clearly can't do because time here is muscle, that you're more likely to get late gadolinium enhancement. The world of cardiac MRI has moved beyond late gadolinium enhancement, and we have now more quantitative techniques that include parametric mapping, where you quantitate T1 and T2. And so there started to become case reports about the use of T1 and T2 in these cohorts. And so Dr. Tadavendranathan and Dr. Zhang put together this cohort study in 2021, where they said, how about we apply these modified Lake-Louise criteria? So LGE plus T1, and edema, qualitative edema plus T2. And does that provide value? And indeed, these qualitative techniques do provide value. At least 95% of patients met the non-ischemic myocardial injury criteria using a modified Lake-Louise. So if it's available at your institution, we would strongly encourage that if you can do T1 and T2 mapping, you should do that among patients with suspected ICI myocarditis. The other rationale is to do that is that T1 value certainly has prognostic implications. So the more affected the T1 value, the worse the patient does. The T2 is a little more problematic because a lot of these patients got corticosteroids, and so we think that the T2 value may acutely change, or certainly more acutely change with the corticosteroids. And so we have this approach, which where you have a patient in whom you have suspected immune checkpoint inhibitor myocarditis. Then you do your EKG, your echocardiogram, including global longitudinal strain. You do measure your troponin. You do a cardiac MRI using modified Lake-Louise criteria. If that's positive, then you have a diagnosis. If it's negative and there's still a high index of suspicion, then you got to do an endomyocardial biopsy. A question I commonly get asked is, well, how about nuclear imaging? And there are all sorts of interests about nuclear imaging and various PET tracers. And I would say that there is value in some PET tracers. So this is a small study using a PET tracer, which was an FAP, fibroblast activating protein PET tracer. And in that FAP, there was an increased signal. FAP is not clinically available, so FDG is clinically available. And this fibroblast activating protein makes sense because it is a marker of fibrosis. But people have asked, well, what happens when you apply FDG PET to these patients? And there's a nice study published relatively recently out of Europe, where they took over a large cohort and they did an FDG PET on every one of them, and they biopsied pretty much every one of them. And then they separated the two groups into biopsy-proven myocarditis and biopsy biopsy negative. No different in FDG PET signal. So it's not a study we recommend. So we don't routinely do or don't ever do an FDG PET among patients with suspected immune checkpoint inhibitor myocarditis. But it's not to say there might not be a role for other tracers. There's a very interesting study on a somatostatin tracer as well, which I'm not presenting. But when in doubt, biopsy. If you have a suspicion that remains after you do your echo, your EKG, your cardiac MRI, and they all don't help you make the conclusive diagnosis, then you should do a biopsy. And pathologically, it's very similar to transplant rejection. And so what is the way you put it all together? And the way you put it all together is you put a combination of pathology plus clinical features. And generally, to break this all down to something very simple, in that if the patient has a pathological diagnosis of immune checkpoint inhibitor myocarditis based on an endomyocardial biopsy, the job is done. If the patient presents with a clinical syndrome and has not gotten the biopsy, then you can make the diagnosis based on the clinical syndrome, increased troponin, and a diagnostic cardiac MRI. If they don't have a diagnostic cardiac MRI, then you can use a reduction in systolic function, the presence of other things like myositis or hepatitis, and an intermediate criteria on the cardiac MRI. So how do you treat? So there's two treatments. There's the non-pharmacological, and then there's the pharmacological. So what's the non-pharmacological? But the non-pharmacological is you admit, and management has got to take place in an integrated unit, typically a cardiac unit, where there's backup pacing available. All immunotherapy has to be held, and it's a multidisciplinary approach. We always involve our oncology colleagues, and I've got a slide or two later talking about that. We treat with corticosteroids once we make the diagnosis. The corticosteroids dose is debated. This was the ASCO guidelines in 2021. They updated the ASCO guidelines for 2022, but didn't actually change what they recommend for corticosteroids. And what they recommend is 1 to 2 milligrams per kilogram of prednisone and escalate in patients without immediate response. I would say that there's a little bit of debate about that approach, starting with moderate doses of corticosteroids and escalating if there's non-response. And the rationale is that we see a lot of patients who don't respond to lower doses of corticosteroids and need higher doses of corticosteroids. So the SITC and NCN and ESMO ESMO just updated their guidelines last week. And when they, SITC and NCCN, they give a gram of solumedrol, and that's what we tend to do here. ESMO updated their guidelines last week and said, give a gram of solumedrol. Neither of them really talked at length about what to do if the gram of solumedrol doesn't work, which is a relatively common question. And we can go into that a little bit later. So are there data to support which doses of corticosteroids? And there are from Dr. Zhang, whereby she showed data that higher doses of corticosteroids are associated with better outcomes. Also, actually, the most profoundly impactful part of her presentation was that the time to corticosteroids, like a time is muscle kind of a conversation, was even more impactful than the doses. So getting corticosteroids on early was more impactful than actually even higher doses of corticosteroids. The challenge with the high doses of corticosteroids is the whole winning the battle but losing the war conversation, which is critical in these patients. And so we may be treating their myocarditis effectively with higher doses of corticosteroids, but those higher doses of corticosteroids may be adversely impacting cancer outcomes. And I think the more recent data suggests that's sadly the case. So these grams of solumedrol that we're using adversely impact cancer outcomes. And indeed, the data would suggest that 60 milligrams of prednisone plus adversely impact cancer outcomes. The other thing that's unresolved is the fact that this is Dr. Charlotte Lee, who is in Cardio-Oncology at Columbia. And Dr. Lee has shown that despite these increasing doses of corticosteroids, that the rates of major adverse cardiac event remain high in it. As shown on the right-hand side of the screen is like rates of major adverse cardiac events by year, and they still remain sadly at around 40%. So we're using more corticosteroids, but we're seeing that still not seeing an impact on MACE. So what happens if the patient fails corticosteroids? There's a term called corticosteroid resistance, which has been seen in the recent literature. And it's tough to define corticosteroid resistance exactly, but I guess broadly you could say if someone gets on corticosteroids and has an event, that's corticosteroid resistant. If someone gets on corticosteroid and has like elevated and their troponin continues to rise, then that's complicated, right? That's probably corticosteroid resistance. But we estimate about 1/3 to half patients who get treated with corticosteroids will need a second-line immunosuppressant. And so what is that second-line immunosuppressant? There are some groups who support the use of infliximab, and it's indeed in the guidelines, it's in the ASCO guidelines. If you look at the NCCN and SITC guidelines, they strictly say no infliximab. And the reason why they say no infliximab is that there's a publication in JITC shown on the bottom left saying that those individuals who got infliximab had worse outcomes. And as you know, there's a black box warning for infliximab with a lower ejection with heart failure. And there are like retrospective data where they have compared infliximab to non-infliximab groups, showing that the infliximab groups do worse as well. So there's some concerning data out there about the use of infliximab. But the infliximab story is also complicated because there's this elegant mouse study whereby they give infliximab up front to mice about to get PD-1, and they show less T-cell infiltration into the myocardium and preservation of global longitudinal strain. I'd be a little worried about that approach. In that preemptively treating with drugs like infliximab might reduce the T-cell infiltration into the myocardium, but it's through the T-cell infiltration into the tumor that the tumor responds. And so I'd be a little bit worried about that, about following that path, about pre-treating with TNF. So what is the escalation pathway if corticosteroids fail, which we've spoken about commonly fail? And these are what's suggested out there: Celcept, IVIG, ATG, abatacept, and alemtuzumab. I'm going to spend the next 2 slides or so talking about abatacept. Started with a case report in New England Journal in 2019 where they rescued a patient with 5 milligrams per kilogram of abatacept. They ended up giving the patient 4 or 5 doses of 5 milligrams per kilogram of abatacept, and the patient who was breaking through on high doses of corticosteroids responded. Abatacept is a very interesting drug because it's been FDA approved and been around for a long time. It's FDA approved for about a decade or more. And abatacept binds CD80, CD86 and prevents the antigen presenting cell to T cell through that CD28 mechanism. And so it stops that antigen presenting cell to T cell. And there are case reports about the use of abatacept. It's been FDA approved for a couple of indications. They're FDA approved for rheumatoid arthritis, adult rheumatoid arthritis, juvenile rheumatoid arthritis, and graft versus host disease. No increased cancer risk, and you can imagine that that would be very relevant, especially for the graft versus host disease, and actually for any patient with an autoimmune disease. And relatively safe, very low incidence of side effects. We have anecdotes, and this is one of the anecdotes I show about a patient who got diagnosed with immune checkpoint inhibitor myocarditis, melanoma patient, 50-something years of age, 58 maybe, presented with fatigue and double vision, and also had a abnormal EKG, new right bundle branch block. Troponin was elevated, comes in and gets a diagnosis, gets started very quickly on here on methylprednisone and Celcept. This is a study. This is a group who actually do combination immunosuppression up front. So all patients with myocarditis, they start them on a gram of salmeterol and they start them on Celcept at the same time. Just speaks a little bit to the practice variability. The challenge with Celcept is it takes quite a while to work. It takes a couple of weeks to work. But you can see the troponin continue to rise and the patient developed complete heart block, VT, and cardiogenic shock. And the attending tells the story whereby they were rounding and one of the residents just said, like, listen, I read this case report in New England Journal where they had a sick patient and they gave that patient abatacept, I think it was a female, and the female patient that they gave abatacept to. Why don't we try giving abatacept to this patient? Because, we're not actually, things are not going great. multiple immunosuppressors in shock, recurrent VT storm. Got 10 milligrams per kilogram of abatacept, and you can see the remarkable decline here in serum troponin. And within a short period, the patient was off all vasoactive agents and in sinus rhythm. If you remember the mouse model we spoke about earlier from Dr. Allison and his team, so they tested the value of the effect of abatacept in this mouse model, and you can see that the mice here shown in green are far happier than the mice shown here in red. So the green are abatacept treated, and the red are those who are treated with vehicles, we would say in my country, and associated with far lower cardiac immune cell infiltration. So this is a study schema which I'm doing with Dr. Yang, and essentially what we're doing in this study is we're going to take this patient where they got 10 milligrams per kilogram, and we're going to give abatacept at randomization. We're going to repeat the abatacept at 24 hours. We're going to give it again at 3 weeks, or 2 weeks, sorry. And again, there's an optional dose at 4 weeks. And that's called the Atrium trial, which is very close to activation at UCLA. And we're kind of excited about that because it's testing a biologically plausible intervention in immune checkpoint inhibitor myocarditis. And so over 400 patients approximately in 50 plus centers throughout the United States and Canada will be randomized 1-to-1 to placebo versus placebo plus abatacept. And we're looking at major adverse cardiac events. We're not looking at soft endpoints here. There's all sorts of the beauty of this study as well as we're collecting a reasonable amount of biomarker data, and that biomarker data includes echocardiography, EKG, cardiac MRI, blood work, tissue samples from the tumor when available, endomyocardial samples when available. And so we hope that this will also act as this open repository for subsequent investigations to better understand this disease. So that hopefully will launch at UCLA relatively soon. So for myocarditis, this is a suggested approach. If left ventricular ejection fraction is normal and no malignant rhythm disturbance, we give a gram of salumedrol. If it persists, we add Celcept. So these are the well myocarditis patients. If the patient's unstable, then we start gram of salumedrol. We talk to our heart failure colleagues, not so much because we think they're going to get a transplant or anything like that, because they've got active malignancy, but more to think about temporary mechanical support. And that's why we recommend that all these patients with immune checkpoint inhibitor myocarditis get transferred to centers like yours, where you can provide that temporary mechanical support. We don't think any of these should be managed in the community, any community hospital settings, because we don't think that they have the infrastructure for when the wheels come off, which sadly they frequently do. And one of the questions I often get asked is, should we perform cardiac screening prior to immune checkpoint inhibitor myocarditis, immune checkpoint inhibitor myocarditis therapy? And the answer is yes. Every patient should have a baseline EKG and troponin. And as you can imagine, many of these patients will present with non-specific symptoms, fatigue, maybe shortness of breath, etc. Because think about one of the most common indications is lung cancer. And so when they present with those symptoms, one of the reflex actions here is to measure to perform an EKG and do a troponin. And frequently, this is a lung cancer cohort, so the troponin will be detectable. And so what do you do with that troponin, which is now detectable? Well, you can do a lot if you have a baseline troponin, which was also detectable, and the two are very close to each other in range. You can essentially say, my concern for myocarditis is low. If the new troponin is far higher than the baseline, then you have a real concern for immune checkpoint inhibitor myocarditis. So that's the real value here. We don't ever, I think we do this routinely now here, where we check troponins prior to starting immunotherapies, and not in one case of over 500 to 600 patients where we've done this have we ever stopped immunotherapy based on a baseline detectable troponin. A common question is I get is, should we perform on-treatment surveillance and how? And there's all sorts of risk factors you can come up with: age, history of heart failure, history of coronary disease, etc. But I got to say, when I step back, there's going to be an awful lot of false positive troponins here, and you're going to lead to a lot of unnecessary testing and unnecessary angst. And so I would say there's maybe, but I would only first test it in the in the context of a clinical trial or clinical study to see if it has value. And honestly, the clinical trials and clinical studies where they test this routine surveillance, they've not found value, because essentially you end up with 20% of patients who get a detectable troponin on immunotherapy, and 1% have myocarditis. So you have 18 to 19% or so of patients who have a newly detectable troponin who don't have myocarditis, and it creates a lot of workup and a lot of anxiety. I'm going to switch a little bit. That was the acute complications of immune checkpoint inhibitor therapy. I'm going to switch a little bit to the potential chronic. And this is a consult for the father. So father of one of our father-in-law of one of our nurse practitioners. And they came to me because he was diagnosed with melanoma. He was in his 60s, maybe early 70s, and he wasn't very active, had a few cardiac complaints and had quite a lot of cardiac risk factors. So he had a cardiac CT, and the still images are shown on the left. And you can't interpret much, but he had non-obstructive coronary disease. And so he went on and had his combination immune therapy for his melanoma. And then he comes into the emergency room a couple of months later with chest pain EKG changes, and he has this coronary angiogram where the cine image is shown on the right, and he now has triple vessel coronary disease. And it's always the relative of the person who's in healthcare for whom this happens. And and so now he ends up undergoing coronary artery bypass surgery a couple of months after starting combination immune therapy, and he had no obstructive coronary disease a couple of months prior to that. And so, the question was risen as why? One plaque, maybe, two plaques sounds unlucky, multiple plaques rupturing in a short period of time sounds like one should ask questions. And you don't really need to ask the questions in much detail, in that we all recognize that atherosclerosis is a model of immune activation, and the role of inflammation and the modulation of inflammation in cardiovascular diseases is completely understood. And these immune cells are a critical part of the atheroma. I'm going to talk a little bit later about the CANTOS trial, canakinumab. And multiple groups have looked at the role of these immune checkpoints, PD-1, PD-L1, and how they may impact atherosclerosis. And this is a particularly interesting paper from a group out of New York, Dr. Fernandez and colleagues in Nature Medicine, where they looked at carotid plaques in patients with symptomatic and asymptomatic carotid disease. And in the ones who were symptomatic, i.e. had recent TIAs or strokes, they had much higher PD-1 expression. And it led that group of investigators who to comment in their discussion, and this is verbatim from their discussion: considering that T-cell activation aggravates atherosclerosis, treatment with PD-1 inhibitors may have unanticipated consequences in cancer patients with underlying cardiovascular disease. So that's what they hypothesized in relation to the findings from their paper. And animal data would support that hypothesis. In animal work, if you block PD-L1, you increase inflammation and accelerate athero. In animal work, if you block PD-1, you increase inflammation and accelerate athero. On the flip side, CTLA-4 agonists actually lead to reduction in inflammation and reduced athero burden. So there are studies in animal models using abatacept where actually they show reduced atherosclerosis and inflammation. And so the question is, does immune checkpoint inhibitor therapy, does it aggravate T-cell driven plaque inflammation and atherosclerosis? And the answer is probably yes. So what's the potential impact? You give immune checkpoint inhibitors, you see an enhanced immune response, you see accelerated atherosclerosis, and you see an increased cardiovascular events. And is this what happens? And so one of our prior fellows went and started asking these questions. Do we have clinical data to support this? And Dr. Drogby looked, and what she found was she actually leveraged the fact that many of these patients had the serial CT studies. And if one looks at patients, so she then went into those serial CT studies and measured atherosclerotic aortic plaque. And she found a threefold increase in atherosclerotic aortic plaque. This was in a melanoma population. And she chose melanoma patients because they were less likely to get, the lung cancer cohort might get TKIs, they might get radiation therapy, etc. There might be a lot of smokers, whereas the melanoma population tends to have a different profile and different therapies. So threefold increase in plaque progression. And the change in plaque progression, that increase in plaque progression was minimized somewhat by the use of corticosteroids and the use of statins. The challenge with the use of statins is that she then went on, there's another feared complication of immune checkpoint inhibitor therapies, which is called myositis. And she went on and said, well, you know, let's think about this if we're going to start recommending statins for everybody on immune checkpoint inhibitor therapy. That we're not doing something bad. And actually, sadly, there's a threefold increase in myositis among patients on statins who are also on immune checkpoint inhibitors. So I don't think statins are the answer. The corticosteroids certainly slowing plaque is very interesting, but again, there's concern about the use of corticosteroids and impacting cancer outcomes. So we need to better understand the biology, where to go next. Dr. Drugby also showed an increase in atherosclerotic cardiovascular events. So she focused specifically on myocardial infarction, ischemic stroke, and the need for coronary revascularization. And so a threefold increase in threefold increase in plaque-related events. So we often turn to advanced imaging to improve our understanding. And one of the advanced imaging techniques linked to atherosclerosis is FDG PET. And also it's widely available because a lot of these patients will get FDG PETs for tracking their cancer. And so one cohort study where they retrospectively measured the FDG PET signal in the aorta among patients on immune checkpoint inhibitor said that there was an increase in FDG PET signal. Second cohort study whereby this was prospective out of the Netherlands, where they did the same thing, except that they followed it, they did the study pre and post. The last study was a retrospective study, which always has some limitations. In the prospective study, both in mice and humans, they found no increase in FDG PET signal. And so the data on FDG PET in the vasculature and the signal and effective signal are a little bit conflicting. And I think the latter study here is probably more likely to be correct based on how these immune checkpoint inhibitors work. If you look at the animal studies, there's FDG PET is mostly a macrophage, and the animal studies show no increase in macrophage content. And there's a small, but the reasonably sample size human study where they looked at the plaque of patients who were on immune checkpoint inhibitor therapies, and they showed no increase in macrophage. What they did show is a more remarkable increase in CD4 positive and CD8 positive T cells in the plaque of both animals and humans. And indeed, I spoke to the pathologist who was part of the study, and they said that this was the most profound increase in CD8 positive T cells that they'd seen in any pathological case. But we need mechanistic insight, and there's all sorts of interesting pathways we could go down. I'm going to talk about CANTOS in a second, which is top left. But there's an elegant paper on PCSK9 inhibition. PCSK9 inhibition may potentiate the anti-tumor effect of immune checkpoint inhibitors. And so that's a really interesting pathway that we could think about going down. But also you could think about things like interleukin-1, interleukin-6, because it doesn't look like antagonists impact the cancer effect. CANTOS is a very interesting study because it showed using IL-1 beta antagonist that you can reduce major adverse cardiac events, shown on the left, and on the right, you can reduce incident lung cancer events. So wouldn't it be really interesting to check the effect of canakinumab in this cohort on reduction of plaque progression in immune checkpoint inhibitor therapy? But there's this mad world beyond PD-1, PD-L1, and CTLA-4. And on this, I should now include LAG-3, because LAG-3 is now also FDA approved. And so we now have four targets which are FDA approved for immune checkpoint inhibitor for cancer. But the world of immune checkpoints, there's immune checkpoints on every immune cell, right? T cells, B cells, macrophages, etc. And they may have differential effects on cardiovascular biology. And so there's a newer approach where they're targeting macrophages. So immune checkpoint inhibitors are macrophages for an improvement in cancer outcomes. And one of these immune checkpoints, so that PD-1, PD-L1, CTLA-4, and LAG-3 are on T cells. One of these approaches is where they're looking at CD47, which is an immune checkpoint which is on macrophages. To take a step back, because I know very little about the immunology, and to take a little bit of a step back, what does CD47 do? Well, CD47 is an immunoglobulin that's found on the surface of many cells in the body. When you produce new red blood cells, there's an abundance of CD47 signal on these new red blood cells, an abundant. And so these are like don't eat me signals to the macrophages. And so the macrophages come along, they're seeing these new red blood cells and the new red blood, and it says, you have a lot of CD47, I am not going to eat you. However, as these red blood cells age, the CD47 content decreases and it passes a threshold, and then the macrophage eat up the old red blood cells. And that's their critical role. But these actually CD47 is expressed widely on cancer cells. And so groups have looked at the critical role of CD47 in cancer biology and said, if we have an immune checkpoint which targets CD47 on macrophages, we may improve cancer outcomes. And those data show that, especially in lymphoma and certain other cancer types, that inhibition has promise. But there's a world of data about CD47 in atherosclerosis and atherosclerotic plaque biology, where multiple studies, including the one shown on the bottom left here in Nature 2016, showed that CD47 is increased in atherosclerotic plaques. And the same study went on and said there's an increase in CD47 in atherosclerotic plaques. And if you inhibit CD47, you actually reduce atherosclerotic plaque. So now we have a completely different paradigm, which is whereby targeting checkpoints which are on T cells might aggravate atherosclerosis, whereas targeting immune checkpoints on macrophages might actually reduce atherosclerosis. And there's some data to support, early data to support that may be the case. This is an FDG PET data where they quantified the FDG uptake. Again, they're looking at macrophages, so this is entirely relevant. And they showed that makrolumab was one of the is anti-CD47 antibody. And so in this study, they essentially took the FDG PET data from the makrolumab study and looked at tracer uptake and found a reduction in FDG PET in the aorta. And so clearly the CD47 antagonist was reducing FDG PET signal in the aorta. So it leads to like interesting conversations about, well, maybe CD47 could have a role, targeting that can have a role in cancer patients for reducing atherosclerotic events, but also can have a role beyond cancer patients if we can use a cancer cohort to better understand non-cancer biology. So in the last couple of slides, I'm going to talk about why do I care about this immune checkpoint inhibitor stuff? Well, you can ask the question, if it's an inflammatory disease, if it's an inflammatory cardiovascular disease, is it increased by the use of checkpoint inhibitors? And so the answer is there's pretty much very few non-inflammatory cardiovascular diseases. I'm struggling to think of any. But if you ask the question, take for instance here, pericardial disease, is pericarditis and pericardial effusions, non-malignant pericardial effusions, are they increased with the use of immune checkpoint inhibitors? And they are. It's an inflammatory disease, it makes sense. How about venous thromboembolism? And it looks also like VTE is increased among patients getting immune checkpoint inhibitors. You know, this is a little tough to tease apart, right? Because you typically go on an immune checkpoint because your cancer is progressing. That's not quite true anymore because these agents are approved for adjuvant and neoadjuvant. But in the older days, that was certainly the case where these were later line therapies. And that is often some of the conversation I'll hear back is that, well, these are later line cancer therapies. Is it the development of cardiovascular disease relevant for these patients? These were later line cancer therapies. These are no longer later line cancer therapies. And so like they're now adjuvant and neoadjuvant, and these patients are expected to survive for decades. So it looks like VTE rates are also increased. The number of clinical trials using immune therapy is breathtaking. 5,000 active clinical trials using immune checkpoint inhibitor therapy in every cancer type at every phase in combination with targeted therapy, radiation therapy, cytotoxics, before surgery, after surgery, you name it, it's been used. So the number of FDA approvals, which now is, I think, over 80, but I'm sure I'm underestimating with that figure, is expected to increase and continue to increase. So what can we do? Well, what we have here is we have this clinical immunotherapy toxicity service. And essentially what that means is that these patients on immunotherapy to get admitted to an oncology-led service, a central service led by one of our oncologists. And there's 5 or 6 oncologists who round in those patients. They have a census right now of 34 patients. And so that's one service taking care of 34 patients, all with immune therapy related toxicities. Of course, they range from pneumonitis to hepatitis to colitis and myocarditis. And so what they do is they get admitted centrally to one service, and then they ask whoever's interested to come and see the patient. And also that feeds into a translational research program, because they all get admitted in one service. And so they get asked if they'd consider, consenting for a translational research program where we collect various samples, because a lot of these patients will go for liver biopsies, will go for endomyocardial biopsies, will have colonoscopies, etc. And so some of them, they are so kind to contribute their samples to help us better understand this. And also this engagement with academia and the FDA and industry is very important. I mean, for the Atrium trial, we were essentially shocked when we went to Bristol Myers Squibb and said to them, listen, there's this toxicity related to immunotherapy. What's the #1 selling drug with Bristol Myers Squibb? It's pembrolizumab, right? By an order. And so we went to the company who produces pembrolizumab, their #1 seller, and said, we think immune therapies are responsible for a condition called myocarditis. You have a second drug in your armamentarium called abatacept. And what would you think about a study whereby we would use abatacept in patients with immune checkpoint inhibitor? So thus highlighting one of the toxicities from their #1 selling drug. You can imagine how that conversation was not a straightforward conversation, but they welcomed us with like open arms. And they were like, we understand that immune related toxicities are impacting patient outcomes and we'd like to do something about it. And so this kind of engagement with industry, I think, is critical and to move this path forward. So last slide, immunotherapy has clearly revolutionized cancer treatment, and the use of immune checkpoint inhibitors is rapidly increasing. 1 in 3 or a little more of cancer patients are eligible. And so it's now one of our pillars. And the world of immunology and cancer and cardiovascular disease is intersecting once again. And I think this intersection is just going to get more profound. So thank you very much for your attention, and I very much welcome any questions. I see Dr. Yang, you have a hand up.
That was actually an applause emoji.
Oh, sorry.
But I think that was as always a masterful tour of really just, I think, as you pointed out, one of the most game-changing, I think, relevant armamentarium novel drugs to the cancer system. And I'd like to open up the virtual floor to questions. Because I don't want to talk Tom's ear off as well, because I always have a million questions for him, but I'll give the floor to other people. Our VA colleagues did ask the question, which you did touch upon, about PCSK9 treatments, which—
Great question, Eric. And so the PCSK9 story is very interesting and full of real biological plausibility. There's an elegant Nature Medicine paper published 2021, I think, or so, so if you take a step back, one of the things about immune checkpoint inhibitors is that they work remarkably well for like 20 to 30% of the population they're administered. Remarkably well, profound impact. They don't work remarkably well for like well over 50% of the patients that they're administered to. And so the world is trying to understand, why is this? The standard answer is because these are cold tumors. They don't have a lot of T cells. And so these are cold tumors. We need to make them hot. And so, but they're also trying to figure out ways of making patients who don't respond to immunotherapies. And so there's multiple different investigational approaches, one of whom is use of PCSK9 based on like the plausible cholesterol plaque to cancer pathway. And in that study in Nature Medicine, what they did was they essentially treated mice with PCSK9 inhibitors. 2 groups. One, all animals were treated with immune checkpoint inhibitor therapies, multiple tumor-bearing models, you name it. they had 4 or 5 different tumor bearing models. And in every one of the tumor bearing models, those on PCSK9, those mice on the PCSK9 had a more profound tumor response. And so that's led to like these like really, really relevant questions about, well, maybe we can use PCSK9 inhibitors to amplify the cancer response to immune checkpoints. And that led us to the next conversation, which was like, if it's going to amplify, if you're going to test it, whether PCSK9 inhibitors amplify the cancer response, maybe we could ask whether PCSK9 inhibitors minimize the atherosclerotic response. And this whole area is going to get even more fascinating because there are now oral PCSK9 inhibitors, which are not too far away from FDA approval. And so it'd be a lot easier to test that, whether, it's one thing to give an injection, right? Maybe not that difficult because these patients are getting infusions, but it'd be really interesting to test the effect of PCSK9 inhibition on both cancer and cardiovascular outcomes in at-risk populations.
Great, thanks so much. So we also have a question from Omid, one of our senior fellows, who also does Cardio-Oncology clinic with me. It's an amazing talk, and always the always evolving question of re-challenging after someone has survived myocarditis. Your thoughts and experience?
Yeah, it's a great question. This is usually when I try and turn off my camera and pretend that I've got like technical difficulties. And so I think, yes, there is likely a cohort. So I'm going to take a step back, Omid, and say there's a paper in the European Heart Journal, Heart Failure, from Dr. Palaskis. And what Dr. Palaskis did was he biopsied a ton of individuals with immune checkpoint inhibitors, who they were worried about myocarditis. And he found a cohort where there was this T cell infiltration into the myocardium without myocyte breakdown. And those were safely re-challenged or continued on immune checkpoint inhibitor therapy. And I think those are individuals who there was a suspicion, but actually those are the individuals who represent that mouse model study in the European Heart Journal, where they gave mice immune checkpoints and they showed a normal T cell infiltration into the myocardium without myocyte breakdown. And so I think that's the cohort where we could probably safely re-challenge / continue immune checkpoint inhibitor therapy. And that's the cohort where we can safely re-challenge. So if you do a biopsy and you find that there's a T cell infiltration but no myocyte breakdown, then it's not truly myocarditis, you can probably continue it in those. The other folks I think about re-challenging are folks who have a relatively benign initial presentation. And especially if that relatively benign initial presentation was in the presence of combination immune therapy, like combined with CTLA4, and you can just knock off the CTLA4 and just use single agent immune checkpoint inhibitor therapy. So that's the short answer to a very nice question. Thanks,
Tom. Our next question is from Marcy Calfon Press, one of your former co-house staff, as saying, does CAC score, coronary artery calcium score, predict toxicity? Any role for screening cancer patients with CAC scores that might predict risk?
And so that toxicity, Marcy, thanks for the question. That toxicity relates to, I think, the more chronic. So there's 2 complications we worry about. One is the acute myocarditis, one is the development of atherosclerosis. And the acute myocarditis, the data would suggest patients with previous vascular disease are higher risk of myocarditis. But actually, I think the more relevant population is, because these are all moving to adjuvant and neoadjuvant, is the atherosclerosis question and whether this thing causes progression of atherosclerosis. And there are unpublished data which actually suggest that it's the non-calcified plaque that progresses when you start immune checkpoints, not calcified plaque. Now, that doesn't answer your question, right, whether pre-existing CAC predicts the progression of atherosclerosis on immune checkpoints. But it does help me think a little bit about the biology, in that it's non-calcified plaque, i.e. plaque that's prone to rupture, that actually progresses on immune checkpoints.
It was a fantastic answer. And yeah, I think that's a really great sort of segue. And I really appreciate the fact that you really divided the talk amongst, everyone's always kind of, obsessed and looking at myocarditis as the exciting new topic. But I think you and your work have really really tried to raise the important questions that in the end, the more potential sinister sort of long-term cardiotoxicity, if anything, may be how, the immune-mediated effects may affect, atherosclerotic metabolism. And we have a lot of work, obviously, to do in that realm. My question amongst many to you is kind of your thoughts, because, I think maybe we may be seeing this. I want your thoughts about the sort of the smoldering, cardiomyopathy phenotype,
Oh, yeah.
as you allude to, we are seeing a growing metastatic advanced cancer survivorship. I mean, here at UCLA, which I'm sure you do too, we are seeing a growing number of people who have had stage 3, stage 4 melanoma cancer for like a decade, and they've been on checkpoint. It's quite incredible, right? Monthly infusions costing thousands of dollars, but these people are alive and relatively well. And obviously, these people are not always being screened, but some of them, either through some event or whatnot, will have abnormal cardiac function or some kind of signs. And it's kind of like, I've had this conversation with Javed Moslehi too. It's a little bit like Bigfoot. It's like we think we've seen probably signs that this phenotype exists. And the question is this a smoldering kind of underlying inflammatory process, or kind of what you referred to in the Michelle paper, like some kind of, T cell related cardiac dysfunction long-term that might be an issue? Because I think this is one thing to kind of study, since so many people, the growing cancer survivorship, will be on these drugs for years. And I was wondering.
It's a great question, and and I think it's fascinating, and so one of the questions we'll often get is, we'll have an individual present with a new cardiomyopathy, not clearly myocarditis because it's so late, and then maybe on like a targeted therapy as well, and so nobody really knows what the driver of the new cardiomyopathy is, because it could be like axitinib related or sunitinib or whatever IB, and or whether it's related to the immune checkpoint. And I think it's the Michelle paper. I think there is a T cell infiltration into the myocardium, which in susceptible individuals leads to progressive cardiac dysfunction. And the question for me is, so they get GDMT, and do they get immunosuppressive therapy, right? That is the thing I'm always struck with. And, I tell you, Eric, up to now, I've not been giving these individuals immunosuppressive therapy, because if I can't show true myocarditis, I don't give them immunosuppressive therapy.
Sure.
But I'm not going to give them infliximab, right? Because like I would be sued to high heavens, because there's like a black box warning the size of, with 82 font, do not give to heart failure. But there's some nice mouse data to suggest that infliximab may rescue that phenotype. But that's where I'm struck, Eric, is that I don't know whether to give these patients some form of immunosuppressant or whether to give them like an anti-cytokine therapy. My suspicion is that we'll end up figuring out that a lot of these are driven by that evil humors will identify a target, a cytokine, and that cytokine can be safely targeted, maybe not with TNF inhibition, but can be safely targeted in these patients. That's my hope.
Excellent. Yeah, very fascinating. Right. It just shows how much we have to learn, and we're very grateful for your collaboration and frankly your discovery of a lot of what we know is from Dr. Neilan's work, and it's continuing to evolve. And I think it's, again, really just a unique opportunity for faculty and fellows and trainees to really be at the forefront of this. And we're really excited to be a part of the Atrium trial, as long as our lawyers let us, and we're although we're a few weeks away, hopefully, from activation. So again, it's really just, we're past the hour, so I want to be mindful of your time as well as everyone else's. And thank you so much again, Tom, for such a wonderful talk.
Thanks very much. Always a pleasure. And have a good weekend, everyone. Always lovely to talk. And thanks for the question.
Thank you, Tom. Thanks much. Thank you.
Thank you. Bye-bye.